I'm going to tell you about work that we've done using operations research, industrial engineering, and data science to fight the pandemic at Cornell University, where I'm located. And this is joint work with a number of wonderful PhD students and undergraduates, as well as faculty members, Shane Henderson and David Schmois. So let me just begin by giving you some context. Cornell is located in Ithaca, New York, which is in the USA, and it's in New York State, but it's a long way from New York City. In particular, it takes about 4 hours to drive there, and it's a rural place. In summer of 2020, my colleagues and the students that I showed you at the beginning did a sequence of analyses in order to figure out whether we could reopen for in-person instruction during the fall semester. And that's what I'm going to tell you about. The analysis in order to determine if we could reopen, and then also the interventions that we put in place as a consequence of that analysis, and what the results are. To jump to the end, this is an editorial in the Wall Street Journal from our president and our provost, Martha Pollack and Mike Kotlikoff, explaining the motivation for reopening based on this modeling analysis. The strategy that we used was to bring most of the students back to campus. Essentially, anyone who was able to travel back to campus was invited to do so. And not all classes were offered in person, but many were. There were constraints on how many we could offer in person because we separated students physically in the classroom. So about 80% of students had at least one in-person class. Students were tested upon arrival to campus. In addition, students were tested frequently during the semester, regardless of symptoms. So that's called asymptomatic screening for people that don't have any symptoms. We tested during the fall semester all undergraduates twice a week, and all graduate students once a week, and then employees were tested at varying frequencies, but many also at once per week. We also used something that we call adaptive testing, which goes beyond traditional contact tracing to test the full social circle of positive cases, people that are related to them socially. For example, if someone on a sports team tests positive, we often would test the entire sports team. All of this testing was enabled by something called pooling, which is a technique that allows you to do many tests using less chemical reagent, and a capability for doing testing that was originally built in order to test animals as part of our veterinary school. And then finally, as part of the strategy, we discouraged travel beyond Ithaca, where Cornell is located. The strategy worked. Here I'm showing you cases during the fall semester. In the chart at the top, I'm showing you the number of positive cases found per day. This is in a population with about 20,000 students and about 30,000 people altogether. In the beginning of the semester, so at the start of classes on September 1st, we saw a peak of roughly 12 to 15 cases per day. And then through the course of the semester, we then were able to control infections on campus, and what you see there are, 1 case a day, 0 cases a day, 2 cases a day from people who acquired infections through outside of campus interaction. And in the bottom, you see the number of tests that we ran per day, peaking around 6,000 on weekdays, and then falling off to troughs during the weekends of about 2,500 tests per day. And you see also test positivity, the red line there, initially being large, when we found these cases at the beginning of the semester in the student population, and then tailing off through the rest of the semester. So basically the strategy worked. So what I want to do through the rest of the talk is to explain the dangers associated with COVID-19 at other universities, focusing on the USA because that's where that's where I'm located, and that's where the focus of our analysis has been, to explain what happened at these other universities that employed different strategies that didn't use aggressive screening. Then the analysis that supported the development of the screening program that I described to you at Cornell. And then I'll say just very briefly a little bit about outlook for the future. So first, COVID-19 at universities that opened without aggressive screening. In the US, there were a diversity of approaches to the pandemic. Many universities chose to simply close for the fall 2020 semester, but many universities opened. And here are some news stories about some of those universities. Many of those universities saw large clusters of COVID-19. For example, at University of Alabama, where just in the first few weeks of classes, that article is dated August 29th, 2020, and I think the semester in University of Alabama started sometime in mid-August. So over 1,000 cases at that university in the first few weeks. And that's a little bit of an extreme example, but it's not that uncommon. Here's a more quantitative view of the clusters of COVID-19 across colleges and universities in the US. This is provided by the New York Times. And this was, I believe, dated only in October 22nd. So, only roughly, 2 months into the fall semester. And you see quite a few universities where the number of cases is more than 1,000, is even more than 2,000. At Clemson there, at that point, they had 4,000 cases. So why does this happen? So the strategy employed by most of these other universities that opened was often to test students when they arrived to campus. Some didn't, but many did. Then to test students who had symptoms, COVID symptoms, so a cough especially, or some of the other symptoms. And then to do traditional contact tracing on positive cases, where you would talk to the positive student, you would ask them about where they've been, who they have come into close contact with. So, 6 feet or less, 15 minutes or more was often the guidance given to students in order to determine whether someone was a contact. And then those contacts would be placed into quarantine in case they were positive, so that they wouldn't transmit virus to others. So that was the approach employed at many other colleges. So in order to understand the effectiveness of this intervention, let me show you an animation. Each circle represents a person, a student. The lines indicate social contact, that these are two people that often come into physical proximity with each other. So they might be roommates, they might be friends, they might engage in off-campus activities together. And the gray circles are people that are not sick, they haven't been exposed to the virus, but they are what we call susceptible. So if they were to come into close contact with someone who is infectious, they might become sick. Then this person who is a pink circle has been exposed. So they traveled, for example, to another city and came into close contact with a positive person. The virus infected them, and the virus is growing within their body. So they've been exposed, but it's early in the course of their infection, and so they are not yet able to infect others. Time passes, and the viral infection grows to the point where this exposed individual is now infectious, so they can now infect other people. And they begin to infect their close social contacts. So the people around them become pink. Now, one of the things about COVID-19 that makes it so hard to control is that there's a relatively long period of several days where a person is infectious but does not have symptoms. And during this period, there's really very little way for them to know that they're positive. And so they can go and they can infect several other people during that time period. And it's just hard to stop. So that occurred in this particular situation. So at this point, once this person has exposed 3 other people, they become symptomatic. They start coughing. And they go to their healthcare provider, they are tested, they are found to be COVID positive. That local health department puts them into isolation. So asks or commands them to stay in a place where they're not going to come into contact with any other people. And then they do a contact trace and ask them who they've come into contact with. The person explains their situation, and the health department decides to quarantine the people who reported as contacts. But it's difficult to report all of your contacts. First, you might not remember all of them. Second, you might be nervous about causing a friend to have to undergo quarantine, which is, not all that pleasant, to be stuck in a room for a period of more than a week. So that might lead you to say something that's not fully true to the health department, or when it's borderline and you're not really sure if someone's a close contact, that might push you to not report that contact to the health department. And then finally, something similar is the nature of some of your contacts might be something that you weren't supposed to do. Maybe you were at a party that violated the rules of the university, and you don't want to tell anybody about that. And so you don't tell them about the people that you came into contact with at the party. So as a result, these 2 people that were missed during contact tracing can repeat the process, become infectious, go on and infect others, and the infections can spread through the entire social network of the campus community. So why does contact tracing miss cases? I went over this. Basically, identified contacts might not know or remember or report their contacts. Also, contacts might not answer their phone. This is an important problem in health departments, where they know the name of a contact, but they can't find them. Also, carriers, as we discussed, are most infectious before becoming symptomatic. They might not report their symptoms. You might kind of have a mild cough, and you might be the kind of person who doesn't want to go to the doctor. And also many carriers, many infectious people never become symptomatic, roughly half, especially among young people. So this is a problem in general. At college campuses, in net, the problem is even more severe. So young people are more likely to be asymptomatic. Young people tend to have more social contact than older individuals. And also there's some evidence that young people are less compliant with restrictions on behavior, less compliant with restrictions on social distancing. Those are negatives, and are significant negatives. On the positive side, on college campuses, in the United States at least, it's probably the college campuses do monitor behavior, especially during the pandemic, whereas in the general population, there's very little behavioral monitoring, and so there's that kind of check on social contact. And then also a big positive is that young and otherwise healthy people are just much less susceptible to having really dangerous symptoms associated with an infection. So we understood in summer of 2020 that this was the situation that we were going to deal with if we were to reopen. And we wanted to understand whether additional interventions, we wanted to understand, first of all, were these problems strong enough to create a problem serious enough that we shouldn't reopen? And were there opportunities to develop additional interventions that would help to keep the campus population safe if we were to reopen? And we did want to reopen because in-person education is often more effective than virtual education, and we knew that if we were to bring students back, that they would have a better social experience than if they were to remain remote. Not as good as a normal semester where people don't need to wear masks, but being together, learning is better than being apart. And then finally, the local, Ithaca is a college town, and the local economy is largely dependent on the students and on the university. So we knew that if we were to have to go virtual, that quite a few people who provide in-person services, both employed by the university and just working in the town, people who work in restaurants, for example, we knew that many of those people would lose their jobs, and that many of those businesses would be severely impacted. And so that was another reason that if we could create a safe environment, we wanted to be able to do that in order to be able to support the local community. So towards this goal of understanding what would be safe and what we could do to make things safer, we built mathematical models. And I'm going to talk about two kinds of mathematical models. There's a detailed simulation. It happens to be what's called a stochastic compartmental simulation. And this provides a very detailed and more accurate estimate of outcomes. And then there's also a simpler set of differential equation models that we used. And these were useful because they allow us, they're simple enough that we can get intuition. We can understand the main effects associated with an intervention. They allow us to check the correctness of our simulation models. And then so we use these two things together in concert in order to work with the administration in order to inform decision making. I'm going to focus on the differential equation models because they're more interpretable, and my goal is to give you intuition. But I'll talk about both. So first, the stochastic compartmental simulation. This describes the population by breaking people into compartments or groups. There are compartments associated with different disease states that you see in this diagram here. I'm going to go ahead and attempt to annotate. So in this diagram here, you see different compartments. S stands for susceptible, E for exposed, D is for someone who's detectable. So if you were to run a PCR test, you would find that they're positive. ID is someone who is infectious and detectable. And you see arrows, and the arrows indicate the order in which people can progress through these states during the course of their time in the simulation. These correspond mostly to the animation that I showed you earlier. Then there's two different symptomatic states. You can either have mild symptoms or severe symptoms. Severe symptoms are something that we really want to avoid. That would be someone who would need to go to the hospital and in addition might need care in an intensive care unit. And then after long enough, you're in the state R, which indicates removed or recovered. So this is someone who typically has recovered from their infection and has developed some immunity. And in a rare set of circumstances, but unfortunately not rare enough, can also indicate someone who has deceased. Then you also see states at the bottom here, QS and QI. So these are people who are in quarantine or isolation. So they're kept, we know about their infection or the fact that they're a close contact, and they're kept away from others. QI indicates infectious people that are kept away from others. And QS are the susceptible people that are identified as close contacts. We don't know whether they're infectious or not, whether they've been infected or not. But in fact, they haven't been, and so they're enduring this this quarantine that's quite unpleasant. And if we were to only have a way to ascertain 100% that they're not, that they haven't been infected, then they wouldn't need to be in quarantine. But unfortunately, we don't have such a mechanism other than just to wait a couple of days and continue to retest. So people progress through these compartments. And people are also identified by demographic groups on campus. For example, undergraduates who live in on-campus housing, undergraduates who live in off-campus housing, graduate students, various kinds of employee groups. So we simulate all of this, additionally applying different kinds of interventions like contact tracing and asymptomatic surveillance. And the product of this is trajectories like the ones that you see down here at the bottom that I'll describe in a little bit more detail in a moment. So here's what happens when contact tracing isn't good enough. I'm showing you output from the stochastic compartmental simulation. These different color lines, so the green line is so the x-axis is time during the semester and y-axis is counting people. The green line indicates the number of people that are not in quarantine or isolation. They're free, moving around their community, and they're infectious. So the free infectious individuals. You see that when contact tracing isn't good enough and we don't apply asymptomatic screening, this group of people rises. The number of active infections in purple, so this is both free and infectious people and infected people who are in quarantine or isolation, those rise, and then lagging it, you see the number of people who are recovered in red rising, and then eventually you reach a point where the fraction of the population infected is substantial in this particular graph, which uses some contact tracing. It rises to a peak of around 35%, something like that. And then the number of susceptible individuals in the population has been depleted through infection, and the number of active infections starts to fall until you reach herd immunity, when roughly 75% of the population using these parameters has been infected. So this is a situation that we definitely want to avoid, because if 75% of the population becomes infected, then some number of those individuals are going to have severe symptoms, and we may have some very bad health events, and we definitely want to avoid that. So one way to understand this is to run our simulation using a variety of different parameters and look at graphs. That's a useful thing to do. But let me give you this differential equation, which is something that you can carry around in your head, and I think can give a lot of insight without the need to run a simulation. So it's a simplified version of the stochastic compartmental simulation where it's not stochastic, and there are three compartments. There are susceptible people, infectious people, and recovered people. The infectious people, each infectious person comes into close contact with other individuals at a rate of beta per unit time. Then the fraction of the population that is susceptible to infection, I should say that each of these variables like ST here indicates a fraction between 0 and 1. So it's the fraction of the population that's susceptible. So what that means is that each time an infectious person comes into contact with beta other people, the fraction of those, the set of people that become infectious is beta times S, because only the fraction S were susceptible. And so as a consequence, people move from being susceptible to being infectious due to infection at a rate of beta times I times S. And you have that down here in this differential equation where the susceptible population declines at a rate of beta times I times S. And you have this term here where the infectious population rises at the same rate. In addition, people recover from infection at a rate of gamma. So there's a flow, there's a decrease in the infectious population at a rate of gamma times I. And so that gets subtracted here, and the recovered population rises at the same rate. So you have this, this set of differential equations, and they produce trajectories that are quite similar to the ones that I showed you before from the stochastic compartmental simulation, at least when the population sizes in those models are large enough. So we can use these differential equations in order to understand when an epidemic happens. So the people are recovering at a rate of gamma, and that corresponds to an infectious period lasting on average 1 over gamma number of days. You can think about people who are infectious as having an exponentially distributed infectious period, and so that's going to, you know, if you're comfortable with queuing models, that's going to imply that that people move out of that state into the state of being recovered at a rate of 1 over gamma. If you haven't seen queuing, you know, if you're an undergraduate and you haven't seen queuing models, that's okay, and you can just think about people flowing out of this infectious compartment at a rate of gamma as corresponding to an infectious period of 1 over gamma days. And then beta is is basically the number of infections that I generate as an infectious person in a fully susceptible population. So an epidemic, intuitively, an epidemic is going to occur if an infectious person, so imagine a population where everyone is susceptible and we insert one infectious person. Then during the early period of the epidemic, when not many people have yet been infected, the number of additional infections that are going to be generated is beta. That's the number of infections I generate per day in a fully susceptible population, times the length of time that I'm infectious. So beta times 1 over gamma. And we give that a special name. We call that R naught. And an epidemic is going to occur if that number is strictly larger than 1. If I infect more than 1 additional person, you're going to get exponential growth in a situation like that. And we can see that that's what the differential equation spits out more formally as a threshold between people being, between an epidemic occurring and not. So remember that the rate of growth for the infectious population is this expression. And then think about a fully susceptible population. So S naught is equal to 1. And that's going to give us an upper bound on the rate of growth for the number of infections. So if you plug in that, you see that the rate of growth for the infectious population is beta minus gamma times I, and that can just be rewritten if you pull out a factor of gamma as gamma times R naught minus 1 times I. So we're going to get, this thing is going to be positive, and we're going to get exponential growth if this term is positive or if R naught is greater than 1. So that's a really important shorthand that allows us to understand whether we're in a dangerous situation or not. You can also extend these models to account for contact tracing. One way to do that is to separate out flows into a recovered compartment that happens when people don't report symptoms. So imagine that people report symptoms, the fraction of people who are reporting symptoms at a rate of alpha. So you can subtract off alpha from the rate at which people recover, and that's this gamma prime, which is the rate at which people recover without reporting symptoms. And then you imagine that each time a person reports symptoms, we find n additional positive cases through contact tracing. And then you get the kind of extended SIR model that you see here, where the new parts are these flows. And then you can work out what are the conditions under that differential equation for an epidemic to occur. It's the condition is that what we call the effective R naught is strictly greater than 1. The effective R naught is the net number of secondary free and infectious people that results from each primary infection. So if you have better contact tracing, so a bigger value of n, then the number of secondary infections that are free, i.e. not quarantined, is going to be smaller. And so by having better contact tracing, you're going to be able to get away with a bigger beta or a smaller gamma, while still being able to keep the effective R naught less than 1. Here's an example of that idea in the animation here. So we had one primary case, this person here, and they generated 2 free and infectious people. The other people in the green squares have been quarantined, and so they're not free. And so if this always occurred, or if this was representative of the number of secondary infections that were created, then we would see that effective R naught was strictly greater than 1, and we would see epidemic growth in this situation. So if you just use those simple models and plug in sort of realistic parameters, what you'll see, for example, is if you plug in R naught is equal to 2.5, which is kind of a reasonable estimate from early in the pandemic without social distancing, and you assume that, let's say, optimistically, 65% of this would be optimistic in a student population, 65% of the population is symptomatic, and we'll assume optimistically that all symptomatic cases seek care, then you can work out what the effective R naught is, and so it's 2.5 times the fraction of people that report symptoms times the number of people that are quarantined based on each symptomatic self-report. You see that in order to keep this effective R naught less than 1 and prevent epidemic growth, contact tracing needs to find more than 90% of the secondary infections created by each positive case. And that's, at least in the student populations that we work with, that's really unrealistic. We definitely don't see that kind of effectiveness from our contact tracing. And so that puts you in a situation where you rely on a reduction in beta. So you rely on people having less social contact than they would in a normal time, and also people wearing masks in order to reduce R naught. And so it's really contingent on the extent to which people, a general large population, is willing to modify their behavior. And not just most people, but you really need everybody, because if you have a small number of people who are continuing to have a lot of social contact, the epidemic will spread, is likely to spread through those populations and then infect other people. So it's really a tough situation to be in. So we developed models and came to believe that reopening without special interventions in fall 2020 was probably not a safe course of action. And so we developed these additional interventions. So like other schools, we test students upon arrival and when they have symptoms, but we also test everybody periodically. So we test during the fall semester all undergraduate students twice a week, many other people once a week. And then we do something that's called adaptive testing. And as I said at the beginning, this was enabled through capabilities that we feel very lucky to have had available. Pooled testing, experience with that in the veterinary college, and also a large testing capability through that entity, and then also a great collaboration with our local health system. So adaptive testing, what is that? So if I'm in a situation like the one in this animation, where contact tracing misses some individuals, then I can identify the full social circle of those people. Let's say that the symptomatic case was on the soccer team, on the women's soccer team. So then I might go ahead and test everybody on the women's soccer team, because I know that those people tend to come into social contact together. So I test all those people and I find these 2 extra positives that traditional contact tracing might have missed. And that will allow me to contain my epidemic. Another intervention is asymptomatic screening. So you can imagine that adaptive testing found 1 additional person, but missed 1 other. We still have this positive case here. So what I'm doing on campus is everybody is being tested periodically. So undergraduates, let's say roughly, the people in the blue squares here were tested on Monday, so I don't catch this positive case. And then the people in these blue squares now are being tested on Tuesday. And so at this point, I find that positive individual and isolate them. And I'm able to contain this cluster. So hopefully that gives you a feeling for the motivation for these interventions through an animation. We can also understand them through mathematical models. So one simple way to do that is you take your SIR model and reconstrue the recovered compartment to include people that are isolated through screening. So this diagram doesn't include contact tracing. And what that does is it simply adds an additional reason that someone might move from being infectious to the recovered or isolated compartment. In particular, it adds this, this T here. So that's the fraction of the population, and thus the fraction of the infectious population that I'm testing on each day. And then if you do the same algebra as before, what you realize is that the epidemic is gonna grow if the effective R naught, oh, there's a typo here, is gonna grow if the effective R naught, which is beta now over gamma plus capital T, is gonna grow if that's greater than 1, and the epidemics are gonna be controlled if that's less than 1. So if you plug in the numbers that we worked with before, you'll see that we need to screen about 15% of the population per day in order to achieve an effective R naught less than 1. So we ran a number of simulations and calculations in summer 2020 in order to understand whether this would work and how frequently we should screen people. What we found was that indeed, if you were to screen people even once a week, or here I'm showing you once every 5 days in orange, and then not screening in blue, and these are different simulations, and I'm showing a histogram over the fraction of the campus population that's infected. We see that if we use asymptomatic screening once every 5 days, the fraction of the population becomes infected is, median of around 5%. Versus not screening, you get more than half the population infected, at least with those parameters. At the same time, we had a huge amount of uncertainty about the parameters that were passed as inputs to these models. And that's a big challenge that you face whenever you use simulation in order to support decision-making especially in a setting like epidemic control, where outcomes are so sensitive to inputs. So we did a huge amount of sensitivity analysis and came to understand that if we screened people more frequently, then that was going to be even safer. That outcomes were going to be robust to misspecification of parameters. We also came to understand that in order to get the best impact, one should target screening. So different groups have different rates of social contact, and what you'd like to do is you'd like to be able to identify those groups and then screen those groups more frequently. One can use this kind of a model in order to understand that, where we divide the susceptible and infectious populations into how those populations intersect with different demographic groups on campus. For example, undergraduates in high density housing, undergraduates in low density housing. And then you can write down a more general differential equation where you think about the infectious population as being a vector, a time varying vector, and its rate of growth is given by this differential equation, where you have some matrix beta which governs how one subpopulation of infectious individuals infects susceptibles from the same demographic group and also from other demographic groups. And then you subtract off from that rate of growth a diagonal matrix which corresponds to people recovering, and then also a vector governing the frequency with which you're screening each of these subpopulations. And if you make a pessimistic assumption in terms of the rate of growth of infections, which is to assume that the entire population, almost the entire population, is susceptible, then what you find is that you need all of the eigenvalues of this matrix to be negative, and that will then ensure that that epidemics don't spread. If one of those, if there's an eigenvalue that's strictly positive, then the corresponding eigenvector is going to be kind of the direction along which these subpopulations will interact in order to cause exponential growth of virus. And then one can understand this more simply. If beta is diagonal, so each subpopulation only interacts with itself, then really what you need is that you need that this condition will hold for each subpopulation, which corresponds to just to many different SIR models with screening, one for each subpopulation. So that led us to run simulations where we tested different subpopulations at different frequencies based on some estimates of the amount of the value of beta, and other parameters which arise in the stochastic compartmental simulation and not in the differential equations. And we then traced out a Pareto frontier over, on the one hand, on the y-axis, the total number of infections that we expected in the campus population, and then on the x-axis, the total number of tests that we would need. Adaptive testing is also, we found to be an important complement to this asymptomatic screening, which we used as well. So that was that's how we developed the set of interventions that we considered. There was also the question of, is this whole thing going to be safer than simply having people not come at all, right? The thing that we understood about having people not come, so just doing virtual instruction over Zoom, was that there were a number of students who had already signed leases who were likely to come to Ithaca even if we didn't offer in-person instruction. And it would have been much harder to mandate testing and to control behavior in this population. And so our model suggested that if we went to virtual instruction, ironically, we would be an even greater risk than if we used residential, if we had people return, and then so we could better control what was going on. And that was an experience at other universities, for example, at Michigan State, where they chose not to reopen, and they had an epidemic grow in the population of students who returned to campus, who returned to town anyway. Let me just briefly touch on this, and then we'll end, and I'll take questions. So in spring 2021, we implemented a number of improvements based on our experiences in the fall semester. Spring was, like in many places, spring was tougher than in the fall. Our outcomes in fall were quite good, whereas in spring they were okay, but still not quite as good. So as the fall, so we had about 500 infections during the spring. Those outcomes over the spring and the fall semester are comparable to other schools that didn't open at all, and so we're glad that we opened, and we're glad that we're able to provide these interventions that we're able to offer students a safe experience comparable to what you saw at schools that weren't able to offer an in-person college experience. We've run over 1 million COVID tests, which is larger than the number done in some US states. For example, more than have been done in Wyoming. For fall 2021, we're hopeful that vaccination rates will continue to rise amongst into populations around the world. We're mandating vaccination for our students, and we expect close to 100% vaccination rates for our students some students are not able to get vaccinated at home, and they'll get vaccinated upon arrival. Classes will be fully in person. There is still a substantial amount of uncertainty, and we're continuing to work through what kinds of additional interventions we need to supply in order to protect the population, especially in light of a various variant, the Delta variant especially, which is becoming widespread. But we're optimistic. So let me end there and thank everyone.